Thank you, Dr. Imad, for a nice introduction. It's an honor again for me to be here to present this topic. Can you hear me when I move around? Yes, you can. Okay, fine. Okay, so the topic I've been given is from heart to brain, cardioembolic stroke, when to anticoagulate and how. No disclosures for my talk. So what I'm going to talk about is briefly what cardioembolic stroke is, why should we anticoagulate, what are the guidelines and what do they say, what's this if you have heard about this 1-3-6-12 rule, what are the randomized controlled trials say about this, then we'll talk about meta-analysis and practical tips from me. Bear in mind, I have only 15 minutes. I'll try to do the justice as much as I can. So, cardioembolic stroke, I'm not going to spend much time on that. Cardioembolic stroke, as the name stands, okay, you get a clot somehow from the heart and it travels to the brain to cause the infarct, to cause the ischemic stroke. 20 to 25% of ischemic strokes are actually related to the cardioembolic from the heart. Most importantly, as you all know, atrial fibrillation is the most common one among the cardioembolic. But there are others like LV thrombus. You have valvular heart disease, and you have cardiomyopathies as well. These are the common ones, but there are others as well. Yeah. But why do we need to anticoagulate? Of course, there is a clot, and you need to break the clot. You need to thin the blood so that it doesn't happen again and it doesn't cause the stroke again. Or if you're already known to have atrial fibrillation, you want to prevent the clot causing the stroke. Antiplatelets reduce risk only by 20%, so you need anticoagulation. And as you know, the anticoagulation we decide by Chaswell score and Hasblad score. So I'm not going to go again into the details of those, but the idea is that although you need to anticoagulate, but remember 1/3 of the strokes will still happen because anticoagulation is not a foolproof, like that after anticoagulation you will never have a stroke. That's not the case. So which one to anticoagulate when we talk about? Again, I'm not going to go into the details. We have established over the years now that DOAC are the first-hand choice for anticoagulation. And warfarin is only limited for those who cannot have DOAC for any reason, or there are certain other indications like mechanical valve replacement and moderate to severe mitral stenosis. So this is my main topic I've been given. When do we start anticoagulation? And I'm going to talk about timings now. So there are several factors which influence the anticoagulation timing. Let's take them one by one. First of all is infarct size and location. So where the stroke is, how big it is, that matters a lot. It also depends on hemorrhage. Hemorrhage doesn't mean obviously that hemorrhagic stroke. If you have a hemorrhagic stroke, you're not going to anticoagulate this patient, at least if it's a presenting stroke with hemorrhage, okay? Here, presence of hemorrhage means that has there been any hemorrhagic infarct, hemorrhagic conversion of an infarct. We also talk about type of stroke, whether it's a lacunar stroke, a very small stroke, again the location matters, and also whether it's a multi-embolic stroke, or whether it's a cortical stroke, so it matters where the location is and what kind of stroke we are talking about. And then the risk factors, of course. When we talk about risk factors both for the ischemic as well as the bleeding risk as well. So a lot of factors influence your decision to anticoagulate. So let's see what guidelines say. If you remember, those of you who came from UK or know UK are a bit more conservative, and they have been in terms of UK Stroke Forum. What they used to say that if you have an AF with an ischemic stroke, you wait and it goes beyond 2 weeks. They were quite worried about starting anticoagulation early on. So they want you to wait for 2 weeks and then start anticoagulation. AHA, on the other hand side, you can just look through. So let's talk about TIA. They said for TIA patient, you start immediately. I'm talking about atrial fibrillation patients who are having an ischemic stroke or who haven't had yet an ischemic stroke. So if we had a TIA and AF, you start immediately. Then they said that if you have a patient with stroke at low risk, you can start up to 2 to 14 days. It's a big window, 2 to 14 days. So it's not weak. If it's a high risk of hemorrhagic conversion, then they say beyond 14 days. And if it's end-stage renal disease, you prefer warfarin or apixaban. So even the AHA were although guiding you a bit more, but not telling you exactly, because 2 to 14 days is a big window. Also, it's you to decide whether it's what's low risk and what's high risk. Europeans, I would say that over the last few years, especially from stroke point of view, have been more consistent and more precise in terms of guidelines. So this is in 2013, my stroke colleagues or some of you who have worked in stroke, I have often said in my rounds as well to the residents that I used to follow, when I was doing this stroke fellowship in London, I used to follow 1-3-6-12 rule. Have you heard of that? So that's the 1-3-6-12 rule, okay? So over the last 10 years or so, we have been following this 1-3-6-12 rule, where the TIA start at day 1, small infarct start 3, moderate infarct start at 6 days, and if it's a big infarct or hemorrhagic risk, you start at 12 to 14 days. So what we used to do, even after coming here in UAE as well, that once you get to the day 6 or day 12, okay, I used to do a repeat CT and see whether there's hemorrhagic infarct or not, or hemorrhagic conversion or not, okay? And then accordingly, you decide to start either at day 6 for moderate infarct or day 12 for large infarct. So that was 1-3-6-12 rule. But there is a new evidence coming up, and that's what I'm going to talk about. So new evidence is here. So first comes timing. The timing trial was looked at actually to see whether we can start early or not. So what they said that if they defined this early initiation versus delayed initiation. Early initiation was defined as less than 4 days, and delayed initiation was defined as after 5 days, so 5 to 10 days. So it was non-inferior. So essentially the timing trial showed that if you start early, lower rates of ischemic stroke and death, and absence of intracerebral hemorrhage. So essentially you will prevent stroke, you will prevent death, but not much risk of intracerebral hemorrhage. Then came the Fisher. Fisher did Elan trial, quite famous trial. So Fisher is my mentor from Switzerland. He actually looked again at the same thing about early versus late, and here is the argument. So he defined even more. So what they did is they defined early if you do within 48 hours for a minor stroke or moderate stroke for day 6 or 7. And they defined late as day 3 for a minor stroke and day 6 for a moderate stroke. So similar to 1-3-6-12 rule. So what I would say that the 1-3-6-12 rule was kind of late in his definition, and early is like you actually deciding quite early. And the outcome was same. So the primary outcome was recurrent ischemic stroke, systemic embolism, all that, and secondary outcome was included in the primary outcome at 30 and 90 days. So essentially, if you start early, the outcome is better. You could see this here. So this is outcome at 30 days, all favoring towards early here. And this is outcome within 90 days, and again, even more towards the primary outcomes favoring here. Then come the Optimus trial. So another trial from Professor David Waring from UK. So he defined it as early as within 4 days, and do not support the current common and guideline-supported practice of delaying DOAC after stroke with atrial fibrillation. So he was trying to say that you do it within 4 days, you don't delay it. He also looked at, in Optimus trial, looking into the details of end-stage renal disease patients as well, and the answer was same, that you do not delay just based on the CKD patients. So based on these results, early DOAC should not be withheld in patients with CKD. So let's look at meta-analysis. The meta-analysis came quite recently in June this year, 2025. This was in Catalyst, where all the famous people like Fisher and David Waring and Nicola from UK, David from UK, as I said, so all of them got together and then looked at these findings again. And they again looked at the starting a DOAC, whether it's early versus later more than 5 days. And for people with ischemic stroke and atrial fibrillation, early within 4 days, reduced composite of recurrent ischemic stroke, symptomatic intracerebral hemorrhage, or unclassified stroke within 30 days. So these support early DOAC initiation in clinical practice. So what is practical and evidence-based? I'm coming up with, whether if you have not heard of, this is 1, 2, 3, 4 rule now. So no more 1, 3, 6, 12 rule. Now it's 1, 2, 3, 4 rule. Simple, straightforward. So Japanese did it actually before this meta-analysis from the catalyst, which I just showed you. So I showed you this catalyst. This was done in June 2025, but Japanese actually did in, I think, for 2022 somewhere. Yeah, 22. So February 2022, they did it. And they divided them into TIAs as 3 stroke subgroups. Mild ones, 0 to 7 NHS, moderate, 8 to 15, and severe, more than 16. So in both Japanese and European populations, they come up with this 1, 2, 3, 4 rule, which decrease the risk of recurrent stroke, systemic embolism, and no increase in major bleeding. That leaves me with, this is my kind of conclusion or summary slide. If you want to take the picture of it, this is what the summary of what I have shown you, that if you have a patient with AF and acute ischemic stroke or TIA, you have a TIA, you start at day 1. You have a mild stroke with NHS of less than 8, you start at day 2. You have a moderate stroke, you start at day 3. You have a severe stroke, you start at day 4. This sounds quite dramatic and quite early on, but that's what the guidelines now say. That's what the evidence now say. You don't wait, because the risk of bleed is not much. I will just leaving you now with the final slide of this. The famous Georgius, I really follow him a lot. He has done a lot of work, and I love the quote, is better swift than sorry. That's it. Thank you.
Yes.